But then, honestly, this GLS topic which I had to pick up is something which is not an easy topic. So what we are trying to discuss today is GLS in practice, which is a new standard for heart failure care. So what is GLS? I'll come to that later. But then this is something which is too theoretical. So please pay attention. There are lots and lots of young physicians, doctors here who would definitely try to pick this skill up when they are doing their echocardiographies. So please listen to this. So as an interventional cardiologist, why I agreed to take this topic? Because this is not a simple topic to take up in just 10 minutes. So what it says is, this is a famous saying by Wayne Gretzky: skate to where the puck is going, not where it has been. So you go where the puck is going, not where it has been. This is basically a metaphor which means you have to anticipate future events rather than dwelling in the past or in the present. So this is what GLS would do for an echocardiographer. And interventional cardiology has always progressed, but then this recent wave of transformational technology in non-invasive cardiology is the foundation stone for development of interventional cardiology. And this is what a future cardiologist will have to bear with. So the outline of presentation is basically an introduction, conventional echocardiography. There is something called a speckled tracking myocardial strain, the LGS, and how to optimize the therapeutic potentials. There is this original study, Azmarda versus generic. So there is no financial disclosure as an individual for me for this talk, but then I would still highlight this because this molecule Azmarda, which the JB Pharmaceuticals has, is the only Indian molecule which has a published trial. So we should be proud of it, rather than just expecting like other companies to present their clinical data. This is the only company, research molecule, which we have in India, made by Indians, which has a published trial. And that is why I agreed to present this also. So if you look at our introduction part, the echo part, the history of echocardiography dates back in 1953, where Inge and Edler had introduced echocardiography to the world. So it was called as an ultrasound rather than an echocardiography. And later it was named as echocardiography in 1954 after the first publication. If you look at the heart failure portion, heart failure is highly prevalent clinical syndrome which you are all aware, with a considerable phenotypic heterogeneity. And non-invasive evaluation of heart failure by 2D echo has been always the gold standard. જે આપણે conventionally measure કરીએ છીએ ejection fractions. We all ask, what is your ejection fraction? તમારું ejection fraction કેટલું હતું? People sitting in the OPDs also would say, તમારું heart pumping કેટલું કરે છે? 30%, 32%. It's just not that. The cardiology doesn't just train there. So, and the traditional classification of heart failure based is on ejection fractions. So which is heart failure with reduced ejection fraction. We are all aware of it. Heart failure with mid-range ejection fraction, where your LVEF is from 41 to 49%. Heart failure with preserved ejection fraction, where it is more than 50%. And this is something called as the new revised heart failure classification, where it is called as heart failure with improved ejection fraction. I'm sure many of you may not be aware of it, but what it is basically, symptomatic heart failure with a baseline ejection fraction of less than or equal to 40%, but there is a 10-point increase from baseline LVEF, and a blood second measurement of echocardiography which comes to more than 40%. A lot of our patients of cardiomyopathies, ischemic or non-ischemic, they tend to improve the ejection fractions, and this is where this heart failure with improved ejection fraction classification is based. So we are targeting these subsets of patients to detect and to treat. That is why GLS and heart failure is important for us. So this is the presentation. But then what are the limitations of ejection fraction? Routine ejection fractions which you are measuring, it is load dependent, it does not reflect your intrinsic myocardial contractility, it has its limited prognostic values, there is a lot of inter-observer variability. I may call some patient as 30% ejection fraction, you may see it, may call it as 35%. So a lot of variability is also seen as far as conventional ejection fraction measurements is concerned. And this is where you have this GLS. or the strain rate. So if you look at this, so this is what a strain does. This is the normal spring which we see. Here is the strain, weight is put, this is a strain which is there, and this two loads are put which is causing deformation. So this is a strain causing deformation resulting from the applied force which is there. So this is the basic principle of, so this strain which is applied can be either a positive strain or a negative strain. So this is where it can be negative or positive. So more the deformation, more the negative strain, lesser the deformation, lesser the strain. But then, is it so simple? No, the myocardial deformation is not such a simple phenomenon to understand. It has its three strains. You have a longitudinal strain, you have a circumferential strain, and a radial strain. So what is a longitudinal strain? If you imagine the left ventricle from base to apex, rather than apex to base, which we are normally seeing, the longitudinal strain is basically shortening of the left ventricle along its long axis. So this is the longitudinal strain which your heart is having. It is just not contracting. There are the fibers which contract circumferentially, they contract radially, and that is why it gives a longitudinal strain. So you have the apical rotation which takes place in your echo, which is counterclockwise from apex, and basal rotation which is clockwise from apex. So they are in the opposite direction. It is like a twisting movement, if you can imagine, and it gives a longitudinal strain. So this is the myocardial deformation. Similarly, is what is a circumferential strain. So what it does is, circumferential strain will cause reduction in the circumferences of the LV cavity, and radial strain denotes a thickening. So if those who are doing the echo would realize that as there is a systole, there is thickening of the left ventricle wall which is there. So that is called because of the radial strain, and the cavity obliteration which happens, that is because of the circumferential strain. So this is typically what a longitudinal strain, circumferential strain, and radial strain is this. All these three combined and give longitudinal strain to the heart, and this is where we have to pick up on echo. And this is where the speckle tracking on echocardiography needs to be done. It's just not a recent phenomena. This speckle tracking has been there since almost a decade, and it has rolled a fundamental establishment as far as detecting your LV systolic function is concerned. There are clinical algorithms which have been identified, and they can determine how much of the myocardial damage which has occurred. As and when the detection of subclinical ejection fractions which are lowering is being detected, the more is the use of this speckle tracking happening. And the most important benefit of this is measurement of strain of the GLS, which we say is an independent predictor of all-cause mortality regardless of ejection fraction in patients with reduced ejection fraction patients. So this is equivalent to cardiac MR studies also which we are doing. There have been trials which have given this modality to be equivalent to predicting the heart failure mortality as to cardiac MR, but has to be done in a perfect manner. So how it works? What you do is, this is an ECG gated. You have to apply ECGs to it, and it has to be ECG gated. The more the heart rate is controlled, the better you can do it on echo. So what it does is, there is speckle identification. Algorithms, they identify small stable speckle which are generated by the interaction of the ultrasound waves with the myocardial tissue. Then they track. The speckles are formed, they track. These identified speckles are then tracked frame by frame throughout the cycle, and that is why we need to make it ECG gated. And then the deformation measurements which are there inbuilt in the echocardiography machine, they pick up those, and then the data output is done. And what it measures, speckle tracking echo provides measures of myocardial deformation or strain, which describes how much the heart muscle shortens, thickens, or twists. So all three aspects: longitudinal strain, radial strain, and circumferential strain. So this is what a GLS is. It measures your myocardial deformation, how much your myocardium shortens during the longitudinal directions. And the standard views which we take, the 4-chamber view, the 2-chamber view, and the 3-chamber views, and these are the different curves which are there. And this is the algorithm which comes And post algorithm, this is the final output which we get. That is the bullseye plotting which we call, which presents different segmental values of the myocardium. And interpretation, what it says is, less than minus 18 is normal, minus 18 to minus 16 is borderline, minus 16 is abnormal, and minus 12 indicates major muscle fiber damage. So this is normal, and as it goes up, it is hypokinetic, akinetic, or dyskinetic. Even the guidelines have started recommending it. They have started giving guidance so as to incorporate strain echocardiography so as to enhance the diagnosis and management of heart failure patients. In 2022, GLS is recommended for identifying subclinical LV systolic dysfunction, which has been associated with high risk of heart failure and recurrent heart failure hospitalizations. And as early, as latest as 2025 heart failure guidelines, they have recommended all echocardiograms should incorporate GLS in your reports. So the clinical applications, this is what we are discussing, is a more sensitive tool for detecting early contractile improvements and LV remodeling, which would otherwise missed by a routine standard echocardiography. It even measures subtle myocardial deformation, providing earlier and more accurate detection of systolic dysfunction, even when your ejection fraction is normal. And this is most important when you are diagnosing or doing echoes of patients who are supposed to take drugs or therapies which are intended to damage your heart function. So this was the first part of the presentation, the GLS and its clinical benefit. And now the innovator Ernie, which changed the face of heart failure treatment, and this is where it is important. And why the Ernie which we are discussing today, the Azmarda, is important. This is because of its co-crystalline formulation, which is mixed. There is a 1:1 molar ratio of sacubitril valsartan, good solubility profile, and enhanced bioavailability of valsartan, causing higher dissolution rate at different pH. So this is what this molecule which we have today with us is there. And this sacubitril valsartan is a first class Ernie by innovator, is a unique co-crystal invention. And this is what Azmarda, this today's molecule which they have come up with, is there. And I'll just come to the, and this is the comparative efficacy of Azmarda safety versus generic sacubitril valsartan, which the study which has been published, and we are fortunate that has been published by Dr. Sandar Patel. He is an interventional cardiologist based in Ahmedabad and a very good friend of us. And this is where he has shown the benefit of this molecule of being an innovator versus the generic one. So I'll just come to the final part of this. What it demonstrated was Azmarda led to a significantly greater improvements in your GLS score compared to the generic population. This study establishes the superiority of Azmarda manufactured by unique co-crystal technology over generic formulations while displaying enhanced LV reverse remodeling in heart failure with reduced ejection fraction patients. Also, it further highlights that the value of GLS as a sensitive and reliable parameter is for early LV ventricular dysfunction detection. So coming to my conclusive slides of mine, you have this strain, the GLS measures myocardial deformation, and the most clinical application of is GLS for left ventricular ejection fraction detection. Fastidious attention to detail. There is a learning curve attached to it to do it, but it's very simple. Once you start doing it, you'll enjoy it. And what are the clinical applications? Pattern recognition, subclinical dysfunction, regional variation, which can be done through either a bullseye plot, average GLS value which is we get, and peaking of strain curves. And where it would be useful in detection of left ventricular hypertrophy causing heart failures, cardiotoxicity of chemotherapeutic agents, aortic stenosis patients, also ischemic heart disease patients, and future is in patients with heart failure with preserved ejection fraction, Regional variation also can be established very nicely, and RV strain and left atrial strain, which are also important parameters which we can detect through GLS. So the key takeaways, the last slide for me. Evidence suggests this conventional LVEF is a parameter to define heart failure, is subject to several limitations. For us, strain imaging analysis, particularly GLS, has emerged as a useful echocardiographic tool. It is more sensitive tool for detecting early contractile improvements also, early left ventricular remodeling also, which would be otherwise missed by standard echocardiography. It detects subtle myocardial deformation, providing earlier and more accurate detection of systolic dysfunction. Even if you get your ejection fractions which are normal, still it would detect subtle myocardial deformation. And this molecule, Azmada, has led to significant improvements in GLS as far as compared to generic molecules which are seen in the market. Thank you for